Our next topic is thrombophilias. Thrombophilia is a group of disorders that promote blood clotting either because of excessive clotting factors or too little of anti-clotting proteins that limit clot formation. Increased blood clotting. Thrombophilias are really quite common. 1 in 5 people have thrombophilia, but most people who have it are asymptomatic, they have no problems, and you wouldn't even know that they have it. However, if they develop risk factors such as immobilization, surgery, or pregnancy, that genetic predisposition plus the risk factor may be enough to promote clots. In terms of pregnancy, patients with thrombophilias have more than their share of repetitive first trimester miscarriages, second and third trimester stillbirths, placental abruption, and severe preeclampsia. And the question is, what do we do with this? Pregnant women with thrombophilias are at high risk of developing venous thromboembolism. And this pulmonary embolism is a leading cause of maternal death in the United States. It is the #1 cause of death in the United States. If we look at women in pregnancy who develop pulmonary embolus, half of them or more will have an underlying thrombophilia. Most of these are inherited, and the most common inherited ones are the factor V Leiden and the prothrombin gene mutation. The less common ones are antithrombin 3 deficiency, protein C, and protein S deficiencies. The acquired thrombophilias include antiphospholipid syndrome. And if a patient develops systemic lupus erythematosus, a third of these patients will have antiphospholipid syndrome. Now, most of these women will do fine. But if they have increase in the antiphospholipid antibodies, plus they have the pregnancy complications, that indicates treatment. What is the treatment? Subcutaneous heparin. Now, heparin is a large molecule. It does not cross the placenta. It is safe for the fetus, but you have to monitor it adequately in the mother. And this is helpful when we're looking at venous problems. Low molecular weight heparin is safer than unfractionated heparin, but is more expensive. And sometimes the third-party payers will not pay for the low molecular weight heparin. Low-dose aspirin is really more if you have an arterial side problem. What we'll do with thrombophilias, if they are less severe, just prophylactic heparin. And this is a lower dose, less risk. But if she has severe thrombophilias, then you may need to give therapeutic heparin, and this requires monitoring of your anti-10A level. If it is less severe thrombophilias and no history of blood clots or pregnancy complications, then you may not need to treat in pregnancy at all, but postpartum, you may very well need to. Because the time which is the highest risk for blood clots is in the postpartum period. The relative risk is 1.5 times the non-pregnant risk antepartum, but postpartum, the risk goes up to 4 to 5 times. Now, postpartum, we can use warfarin because it, although it crosses the placenta, after delivery is not an issue. This is safer for the mother, and so we will use this for 6 to 8 weeks. It is safe to use during breastfeeding, and so is the preferred treatment postpartum. And that is the end of thrombophilias.